So hello, everyone. I'm with you today. My name is Caitlin Esposito. I work for the Bobby Jones, Chiari, and Syringomyelia Foundation. Again, I will reiterate that I do a lot of the programs and the research, educational stuff. I'm joined tonight. I'm actually still in the office with Dorothy Poppy and Mary Poppy, who are the executive director in the programs and events, respectively. And then today we also have with us Dr. Roger Kula, which is actually awesome because Dr. Kula is one of the only neurologists that works in the field of Chiari in such a way that actually does a lot. So I actually am going to have Dr. Kula kind of talk about how he got into this field to start with. So I'll have you go first. So Dr. Kula, I'd love to have you introduce yourself a little bit.
Yes, well, it's a pleasure to be here once again with all of you, my dear friends and family. My sister's tuned in with us also. I'll take a shout out to her. Yeah, I began my practice pretty much in neuromuscular disease. I was at the National Institutes of Health for a few years after my additional residency training in San Francisco, came back to New York, which is my kind of home, and started practice at downstate in Brooklyn. And we had began a neuromuscular clinic there, and that rapidly, by my association with Dr. Millerat, who said, now, why don't you take an interest? We have these Syringomyelia patients, and they have a lot of motor problems. And I became interested in that because I had only seen, as many neurologists, maybe a lot of the patients don't realize, but most neurologists only see 1 or 2 Syringomyelia patients in their whole practice lifetime. It's that rare for them. They oftentimes get shunted over to neurosurgeons who manage Syringomyelia. But most neurologists have very little experience with it. You wouldn't think that would be the case, but it in fact is, because Syringomyelia is so rare. And it tends to be a neurosurgical problem rather than a neurological problem. So I became interested in that because of my relationship with Dr. Millerat, who was at that time attracting a lot of Chiari patients. And he was doing a lot of... He was doing a lot of secondary surgeries for patients who had an initial Chiari decompression and then had problems subsequent to that. It seemed to help for about 6 months, and then they had recurrence of symptoms. And so we became sort of a field house for patients that had poor outcomes from Chiari surgery. And so what that did is it availed us with the patient population, which was very interesting and in need of better understanding. And that sort of became our stimulus for trying to approach problems with Chiari and Syringomyelia as time went on. So that began in the early 90s. And then when Dr. Millerat moved over to the North Shore campus, I followed him a year later, and we kind of continued that in real time and developed the first multidisciplinary kind of Chiari center, or one of the first ones in Long Island at North Shore. So that's how I got my start, and here I am today. That's almost exclusively what I do. I don't see that many neuromuscular patients anymore, but and actually, to be honest with you, I'm not seeing any more patients, period, because I'm retired. But I'm happy to be here today, and it's a pleasure to share the stage with you guys and be of any help I can to the patients out there, which has been my desire all along. So
yeah. I thank you so much, Dr. Kula, for everything you do. I know neurology is a poorly staffed, I don't really even know how to say it, field for Chiari, because like you said, it so often gets pushed off to neurosurgery. And then I do want to mention that you got your start at Downstate in this field, and I actually just completed my Master's of Public Health at Downstate, so I'm a big fan of Downstate as well.
They have an excellent public health program, so you're among the best. It's
I'm a big Downstate stan.
Brooklyn.
Brooklyn. So I guess we can get kind of started. I'm going to ask the first question first, just because they're all sort of treatment related, the questions that we got. And again, I do want to reiterate, anyone who's on the call live right now, if you have any questions, please feel free to post them in the chat and I will ask them throughout the night. But I'll start with the first question that we got in. This is a patient with Ehlers-Danlos syndrome and craniocervical instability. They also have bilateral compression of both internal jugular veins. Oh boy. And they also have thoracic syrinx in the T4, T5 region, through T9, and some scoliosis. They've been told that Chiari is not from the skull being too small. Had sitting MRI, supine flow was not blocked. How do you find out the cause of the Chiari? So I guess in this case, is Chiari the problem? So
Well,
this patient, again, to reiterate, Ehlers-Danlos syndrome, craniocervical instability, thoracic syrinx, but they may or may not have a Chiari. So what?
Well, this is an interesting question because it brings up this conundrum with the terminology. Because if the patient doesn't have choked tonsils and tonsillar compression and doesn't really have a Chiari. So as the definition of Chiari first came about after the mid 1800s, when Chiari first described autopsy cases of patients that had terribly restricted posterior fossas and tonsillar compression, spasticity, and really a terminal illness, more or less. These were the severest of the severest kind of Chiari patients who presented with occipital headache, ataxia, and spasticity because of compression of the spinal cord, and then later development of Syringomyelia. This is how the definition first came about, and then we got into this conundrum of what's a Chiari? Is it 5 millimeters, or now we say that craniocervical instability and EDS can mimic Chiari. It's not a Chiari in a sense. It mimics Chiari because the symptom presentation is so similar because of the disturbance at the craniocervical junction, and the dynamic aspect of compression of those structures because of the instability associated with connective tissue disease, and namely EDS. So I don't know, did that answer the question?
I mean, a little bit. I guess really the question is, what really are the causes of Chiari? Because if cine MRI is not showing any kind of blockage of CSF flow, what are the different things that could cause Chiari?
It's not really Chiari, you see. Right. A Chiari, when you get back to the basic terms, a Chiari, as it was first described, was really a small posterior fossa. Now that's probably just a little bit over 50% of the cases of what we now call Chiari-related diseases. And so it was initially thought to be the whole problem, but it's not anymore because craniocervical instability, tethered cord syndrome, and post-trauma cases and the like have expanded what we now look at as Chiari-related disorders. So maybe, to get down to it, when you look at the series of cases that we had, over 700 or 800 cases, the classical Chiari was only about 50% of those cases, The remainder were craniocervical instability, post-trauma cases, and other odds and ends of cranial synostosis cases where there was congenital constriction of the whole brain. So it gets more complicated. Go ahead.
Yes, there are a couple of questions, and I'm going to trigger warning this a little bit because we're going to talk about suicide. Does Chiari malformation cause some inadvertently suicidal tendencies in a child? So theoretically, if the pain was bad enough, could that cause like chronic pain in such a way that maybe they could start developing some depression or serious suicidal ideation in your experience?
Yeah, that's exactly the issue. I mean, there's no association of cognitive or mental issues or suicidal issues with Chiari by itself. In my mind, it's the progression of chronic headache and oftentimes unrealized etiology for that headache that leads many patients to be despondent and oftentimes thought to be neurotic. And as we say, you know, most patients are sent to 4 psychiatrists before they see a neurologist or a neurosurgeon, which is not the best of situations. But chronic headache is one of the most common problems in mankind. Probably about 30% of the population has headache from time to time, and many of them, for many patients, it's a very severe problem. It's not a life-threatening issue for the most part, so that it doesn't raise to the level of other disorders that are chronic and progressive, leading to terminal illness. It's more or less a wearing away of the will and a wearing away of the patient's resilience in dealing with the chronic problem that just seems to be day to day. It's more punishing than migraine, for instance, because migraine attacks are classically understood. They're 2 to 3 hour headaches that come periodically. They can be very severe, but they occur periodically. Some people have 1 or 2 a year. Some people have 1 or 2 a week. But Chiari patients oftentimes will say they have always had headache. It's one of the classical features of the Chiari. They're never free of headache. It just is punishing in the sense that when they try to do something, the headache gets worse. So there's this classical exertional component to the headache, which is punishing, you know. So every time you try to do something that for most part should be pleasant, like going on a roller coaster or riding a horse or jogging or having some physical activity, you get hamstrung by the fact that the headache becomes more severe and you have to stop what you're doing. This leads a lot of patients to actually gain weight because they don't have much activity, and increase in weight kind of aggravates the problem as well, because we add a component of pseudotumor or pressure increase associated sometimes with that, which can compound the problem of headache.
Can you speak to a little bit how the pseudotumor can exacerbate some Chiari symptoms, or?
Well, you know, where the rubber meets the road is really in the posterior fossa, where there's this choke point at the craniocervical junction. So when you increase intracranial pressure, there is a certain impact of pushing the tonsils further down. So coughing, sneezing, laughing, crying, all these things aggravate the headache. And you know, Dr. Millerat used to say it hadn't been very well looked at, but there may be a problem with the absorption of spinal fluid as a result of chronic pressure on the absorptive capacity, the absorptive channels within the central nervous system around the absorptive areas near the sagittal sinuses. So that's not been very well understood, but in any event, patients with Chiari develop not maybe to begin with, they have cough headache and exertional headache, but as time goes on, they just have chronic punishing headache that seems to get worse when they do, the more they want to do, you know. And if you have a headache and you go to an emergency room and it's the worst headache you've ever had, you'll get a CAT scan, an MRI scan, and see a neurosurgeon. If you go to the emergency room 3 times a month or 3 times a year, you're going to get nothing, and you're going to be put in a room and getting a migraine sort of approach with Toradol and Benadryl and be sent home, oftentimes with no studies, because it's a chronic headache. And if you had a headache for more than 2 months and you haven't died from it, you probably don't have anything too serious. So you get turned around in emergency rooms. So many patients are saddled with the issue that they never really get fully evaluated early on, and they just turn into a chronic headache person, bounce from doctor to doctor, and you know, they don't get any satisfaction. So their real assessment oftentimes gets quite delayed, which is part of the problem.
Yeah. A little bit too, that something came up in the chat. A fellow Chiari sufferer recommended a cocktail of Tylenol, Benadryl, and caffeine pills for severe Chiari headaches. For her daughter's severe Chiari headaches. They've tried it several times. It doesn't seem to work. and nothing else really does. Is there any mechanism at work in this particular combination of medications? So just to reiterate, Tylenol, Benadryl, and caffeine.
Yeah, so that's kind of approach for migraine. All right, but the Chiari headache is not a migrainous headache, really. It gets treated that way because migraine is so common that if you see a headache patient, 99 times out of 100, they're going to have migraine, not Chiari. We don't approach those patients in the same way. The idea should be to identify early on the cause of the headache and treat Chiari patients more appropriately with medications that may decrease the production of spinal fluid. We use shunts, to treat intracranial pressure, but there's only one medication really, or two, that affect the production of spinal fluid. And that is Diamox, methazolamide, neptazane, and Topamax, which also decreases CSF production. But we have very limited medical strategies for doing this, but the ones that we do have are poorly used, or not often used, So that's what we try to educate the neurology community about, because everybody's treated like a migraine, and when that fails, doctors tend to say, well, the patient's just a bad patient. It's not, if my treatment doesn't work, it's the patient's fault, so.
Right. And that's super unfair. So I guess to that, before we even move on, is how do you identify, how do you understand the difference between a migraine headache versus a Chiari headache? So what are the different things that someone should be looking out for to tell if they're having a migraine? I know I've had migraines before, but I've also had occipital headaches, which are at the back of the head. So how do you know exactly what you're having?
Okay, so a typical migraine headache comes on. Most migraine patients are totally free of headache in between migraine attacks, all right? And so the migraine attack can be triggered by some things. We know it can be triggered by red wine. It can be triggered by menstrual cycle. It can be triggered by beans that have vasoactive substances in them. It can be triggered by a number of things. Chocolate, for instance, which should be delightful, but is a well-known trigger of migraines. Processed foods, so salami and meats of that type, those can also be triggers. But the trigger for a Chiari headache is really exercise and exertion. So if the headache is exertional in nature, we got to think migraine doesn't tend to be that way. If you do have a migraine headache and you try to lift a heavy weight, you're probably going to have a little worse headache, but it's not exactly the way the Chiari patient experiences this aggravation, So Chiari patients are also likely to have headache that's almost continuous. Oftentimes will tell you, in fact, children will tell you, they don't know what a headache is because they've always had a headache, And in fact, I remember one of the first patients I saw when we were just getting together with Dr. Miller was a 10-year-old boy who was a couch potato kind of. He was a little overweight. He came in and he was not very interactive, but he was a bright young child, and he didn't really complain of headache. We finally, he was evaluated, he had surgery, and the day after I saw him, he was active and motivated. He was in the playroom on the floor, which he hadn't even gotten to before the surgery. He had railroad tracks of sutures down the back of his head, and I said, "How are you feeling?" He said, "My headache's gone." And that's an impressive statement from a kid with just post-operative from an operation like that, who said, "My headache is gone." And I said, "You never complained of headache." He said, "Well, I didn't know what I had." So it's unique experiences like that make an incredible impression on you as to what this headache can be like. And so for many patients as a chronic headache, they really don't understand what a headache is or what a headache isn't, from childhood, So Chiari, because of the issue of the frictional forces and the thickening of the membranes around the posterior fossa, tends to present a little bit later. Certainly kids present with it, which is not uncommon, but in the adult population, patients begin to get symptomatic in their early 20s and late 20s and early 30s. Part of that is because they have continued frictional forces in the posterior fossa at the craniocervical junction that thicken a lot of these membranes. So the restriction becomes greater and greater and greater, and it's a very gradual process that is difficult to put your finger on. The patient just realizes they're getting worse. And, you know, if you've had a headache for 3 or 4 years, you know, nobody thinks there's anything new to look at, you know. So they frequently get overlooked.
Yeah. Before we move on from sort of, we had been talking about suicide earlier. There's some cognitive issues that also come up a lot with Chiari. So a question came up in the chat function. What is brain fog, Chiari fog? And have you found any kind of treatment that's best for managing it? Is surgery the way that you kind of deal with that, or do we not even know what brain fog is and how to treat it?
I don't think we actually know. You know, it's kind of a mix of things. I mean, Dr. Miller and I, we also used to talk that maybe there was a certain amount of intracranial pressure by the resistance to forces at the posterior fossa that led to maybe pressure in the cortical structures that led to some cognitive kind of dysfunction. But there's been very little. Some people in the Chicagoland area, University of Chicago, Dr. Oro, and a few people have looked at the cognitive issues as well as us, you know, in Chiari, but it's very kind of nebulous, and it also is contributed to by oftentimes the use of pain medication and sedative medications and Benadryl and things like this that do cause cognitive clouding. And pain is a great depressant, more or less. You know, you don't feel up to doing much, and that puts the spin on, and that leads to this idea of, you know, suicide is not something associated with Chiari, but suicide is certainly sometimes associated with chronic severe headache. In fact, you know, men that have what is called, you know, chronic cluster headache frequently commit suicide because the headaches come on in clusters, a very severe headache, usually in the middle of the night. And there's frequent suicides, you know, among those. Men are more likely to suicide than women because women are more forbearing, and so that's a particular association with cluster, what's called cluster headache, which is uniquely kind of more of a male migrainous variant, you know. But in Chiari, I think there really is no associated with that. I find Chiari patients are usually quite high functioning patients, and they're, you know, there may be a selection bias, and that a lot of these patients get to specialized centers, but I think, you know, they're very self-motivated and to try to get at the base of this. It's just that the medical community kind of lags behind in their understanding of this particular kind of headache problem and what can be done to treat it, and when is surgery indicated.
So have you ever noticed that after surgery that brain fog has gotten better or worse?
Oh yeah, I think medication.
Pain meds being used, and then there's actually a question specific to the medication Concerta, which is a sort of ADD medication. So I wonder if you have any comments about that.
Well, you know, these medications are stimulant medications, which kind of counteract sedative medications. So it makes sense that people will be a little quicker on the draw. In fact, they did a study, it's kind of comical in a sense. They did a study of medications that, you know, are used for stimulant medications and gave them to air traffic controllers, and they all actually were much better at air traffic controlling. So the question came up, should they all be on stimulants or not? Or should we all be on stimulants? Or should we put it in the drinking water, you know? So some of these things, you know, it's not surprising that they improve function in someone with a chronic headache or chronic pain, or that's on sedative and other medications that may make you a little more dull-witted as you undergo continuous treatment. But we try to stay away from narcotic medications, for instance, and anti-stimulant medications in particular, because they produce a conundrum of problems that just aggravates things as time goes on. So there's no place for them really in the long run. The treatment for Chiari headache is medical treatment, which is not usually long lasting and is not often 100% effective. I mean, Dr. Miller, when he used to talk, he would kind of chortle, that I was dabbling with these silly medications when what these people really need is surgery, So, but it was true, I mean, patients would come around, they would get some relief. I have patients that did well on some of these medications for 5 or 10 years, but they ultimately, the natural history of this is to come to surgery at one point or another. There's certainly, I mean, we have patients that have suffered with Chiari for 30 or 40 years and, somehow get by without surgery. But don't forget, as you pass 25 years of age, your brain begins to shrink. And by the time you get to be 65 or 70, there's a lot more room up there. So you don't tend to have as much pressure-like problems, and the tonsils gradually lift. In fact, some of the work that Dr. Keating's done with looking at tonsillar herniation from the teenage years into the early 20s and 30s, your tonsillar descent sort of peaks in the mid-teens and the early and really late teens, maybe early 20s, and then as after you're 20, you begin to lose, I don't know, something like 100,000 neurons a day, and your brain begins to atrophy gradually, and that sort of lightens the load on the Chiari problem. Tonsils, if you monitor them in a natural history of things, they begin to elevate somewhat. So this 5 millimeter rule is, as Dr. Keating talked about today, is really a bell-shaped curve. It's the margin at which less than a couple of percent of 1 or 2% of people, have tonsils that are that descent. So you can be normal and have tonsillar descent of 4 or 5 millimeters, or you can be have Chiari. Now, tonsillar descent by itself does not oftentimes indicate the amount of lateral tonsillar compression there is. So you want to get a good look at all the imaging that's available. So, and axial imaging of the craniocervical junction, because in a number of patients there's lateral impingement on the tonsils compressing the brainstem laterally, which can you don't see in the central cut of the usual demonstration of the tonsil. In fact, the tonsils are a little on either side of the midline, but we don't tend to see them a degree to which tonsils can wrap around the brainstem and produce lateral compression, which can have a lot more impact on things like vestibular function, hearing, and other things like sensory function,
Yeah.
So,
kind of before we get away from the medication questions, there was a question that someone's child had been given basically an antihistamine for debilitating headaches. Is that something logical that would work, or is there some reason?
I don't see that being of any particular benefit. I mean, if patients have Chiari headaches, I mean, Diamox can be used in youngsters as well as teens and adults, and does produce some, relief of those chronic headaches. It's used in Pseudotumor a lot, which has many resemblances. So you can have Pseudotumor and not have Chiari, all right? But if Pseudotumor complicates the Chiari process in a number of circumstances. So the treatments are kind of the same. The causes of many of these things are multifold. The treatments are meager. There's really an armamentarium aside from surgery is Diamox and methazolamide or neptazane, which is a little bit longer acting, and Topamax. All right, Topamax has become the migraine doctor, the headache clinic's silver bullet, because almost everybody is placed on Topamax. Topamax has a use in migraine. They don't think about it in affecting intracranial pressure, but it does have a carbonic anhydrase effect like Diamox. And I think a lot of it may be relieving mild increases in intracranial pressure. But Topamax is used in migraine as an anticonvulsant because there's a theory of migraine that says it's aberrant discharges from the hypothalamus that lead to the spreading activity in the brain. That's what's migraine. We know darn little about migraine presently. Even, there's still a big discussion about whether it's vasoconstriction, vasodilatation, or really a hypothalamic discharge of spreading depression that causes problems that affect vision and other things. So migraine is still not very well understood. It's amazingly as common as it is.
Yeah. I think to get we're going to start moving towards treatment and stuff. So have you ever noticed, I know you started answering this before, but I think we got derailed.
Yeah, go ahead.
Have you noticed that the surgery...
I tend to talk a lot, so...
No, don't worry.
Please
it's important stuff. Have you noticed that surgery improves brain fog or fatigue at all?
Yeah. No, I mean, patients will, you can, one patient, I remember one wife came up and said, my husband had the surgery, his sense of humor came back. And I said, how do you lose a sense of humor? Well, it was a personality factor that he had a particular kind of sense of humor. And she said that it really incapacitated him in a sense, and it came back after surgery. So, I think, those things are complicated to understand, but they're certainly real observations. And certainly brain fog and cognitive function and all that improve after effective surgery. So the problem is that how effective is the surgery, and how aggressive is the surgery? Dr. Millerant and Dr. Bolognese had aggressive approaches to surgery with tonsillar resection and generally good effects. But many neurosurgeons are a little hesitant to go and whack the tonsils off because the vertebral arteries lie just below that. It's a dangerous area to go into, and it's a very risky area unless you're particularly experienced in that. And so a lot of them don't venture to do that. Once you've resected, once you've gotten into that area, the tonsils then become, there's arachnoiditis that takes place, all right? When you just take the bone off, and so now it's a bit more difficult surgery to open the dura and shrink the tonsils again. And I think one of the contributions, maybe not widely understood, that Dr. Miller and Dr. Bolognese had is they attacked these patients aggressively that way and were very successful in improving outcomes with secondary surgeries. Because we had a habit of seeing a lot of patients who had a standard bone-only decompression and needed to come back. About 25%, and Dr. Keating and other people have said, about 20% of those patients need to come back for another surgery. And that second surgery is a lot more complicated.
Yeah, absolutely. So I guess we're going to go into the neurology specifically. There are some neurosurgical questions that I think I'm going to leave for another Q&A session because because you're here, I think it's really important to ask these after surgery questions.
As one of our nurses, I'm not neurosurgeon.
Yeah. So a patient that might be like a couple years out of surgery, their Syrinx is gone. There are residual motor problems in the hands and some subjective circulation issues. Are these Chiari related? Could they be? There never seems to be a definite answer when this particular patient goes to their doctor.
Yeah, I remember that question. It's Syringomyelia by itself damages tracts in the spinal cord. It damages pain pathways, all right, that cross centrally in the center of the spinal cord. And so there's this classical feature of Syringomyelia, which is called a dissociated sensory loss. People have very fine touch sensation, but they lose the sense of pain, which is very peculiar. People can't understand, how can I burn myself when I can feel everything so acutely, and yet I don't feel. I burn my fingers with cigarettes. But this dissociated sensory loss is the classical description, which that's how neurologists began to identify Syringomyelia. By the time you identify that, the spinal cord is damaged, pretty beyond repair. When you go in and do anything that relieves the Syrinx, namely shunting the Syrinx, or more importantly, first relieving the Chiari, the constriction at the craniocervical junction, which frequently will collapse the Syrinx. Early on, when people started doing this, they would do a decompression and then shunt the Syrinx. We found that, if you didn't need to do that, you didn't need to touch the spinal cord, because you can damage tracts. If you just relieve the constriction, the Syrinx collapses spontaneously. If you relieve the tethering and thoracic spinal cord, the thoracic Syrinx oftentimes withers away without necessarily having to shunt the Syrinx. So anytime you poke the spinal cord or put a shunt in there or a hose in there, you're going to have some permanent lysis of tracts and the potential for neurological symptoms that may be persistent. So a lot of times you say, whoopee, the Syrinx collapsed, but 15% of those patients, the sensory symptoms and the pain gets worse, because now these tracts that were separated come together and they begin working again, but they're all disconnected, and they produce bedeviling sensory problems and pain, which oftentimes is mistaken as psychoneurotic and drug-seeking pain behaviors, but it's really generally not the case.
Yeah.
When there's a history of syringomyelia, I mean, you release the Chiari and the Syrinx collapses. You look at that patient. Patient has no more Syrinx. Spinal cord looks almost normal. I had a woman from Staten Island who said she had to walk around the house without any clothes from the top up, because her spinal cord looked normal, but she couldn't stand to have clothes on. Anything that touched her arms or her torso was excruciatingly painful. And so this is something we call allodynia or dysesthesia. And it is something that's uniquely associated with syringomyelia, which is a nasty, nasty problem,
Yeah, kind of to that, there are a couple of different questions about balance issues. So I'm going to try to combine these two questions. So
sure.
There was one adult who was in an auto accident many, many years ago. They had a shunt, couple brain surgeries, walking was difficult. They found that writing was exhausting, even just writing. They began doing martial arts, which made it a little bit better, and then they stopped because of COVID and everything shutting down. And so they had noticed that their temperature, fatigue, and balance issues were way off after not having balance. And then also, this is a completely different situation, but in a 6-year-old, they also realized that they had decompression and then still maintained some balance issues after that surgery. So A, what causes that retention of balance problem? And then B, what do you do after you've had the surgery and it's still not getting better? What do you do to treat that?
Well, I think you have to have a situation where you're continually reassessing what the circumstances are. There are things that can be looked at, like motor conductions and spinal cord stimulating studies and conductions studies that can elucidate possible continuing problems. There can be secondary problems. Chronic demyelinating polyneuropathy problems from damage that may be triggered by earlier damage to the peripheral nervous system, diabetes and other things that can complicate things. So you have to kind of continually reassess those patients. When the Syrinx collapses, that does not mean that there is all the spinal cord is normal. The spinal cord, the tract changes and the subtle changes would only be apparent on autopsy series, where you can see there's actually degeneration of these tracts. You really can't oftentimes see that on MRI scanning. Now there's more sophisticated MRI studies to track, being able to identify tracts, and that we may get a little better at that as time goes on. But a lot of that, we just can't image it. But so you still want to look for recurrence of Syrinx again. Even after a collapse, it can recur. And look for other modalities of problems, you know.
Mhm.
Constantly a value of a point of reevaluation. You know, the problem is that people say, well, you had this, you had that, we treated it. There's nothing more to do. That's not always the case. You have to reassess.
I think before we even go on, something that would be really helpful is if you were to say someone had already had surgery and they're coming back to you as a neurologist to kind of work out some of those lingering problems. What is the tests? What are the clinical batteries that you're going through to kind of determine how you're going to treat them going forward? What can people expect?
Well, I think first, which doesn't happen all that often, is you want to listen to the patient, you know, and see what the issues are, you know, and where they may arise from. Are they residual issues with respect to a prior Syrinx? Then you can approach that with certain neuropathic pain treatments like gabapentin, Topamax, other things like that may be helpful. You want to investigate nerve conduction studies and relook at the imaging of the spinal cord again, just keep a handle on what may be evolving. Once you do a series of imaging studies, that's not the end of it. I think many patients need to be imaged 3 to 5 years after their surgery, because people say, well, you had the surgery, so you have these chronic problems, but there can be something else going on. You can have recurrence of the Syrinx or development of a thoracic Syrinx where it was a cervical Syrinx initially. So it's arachnoid cysts and other things that can be chronic evolving problems in the spinal cord region, which are important to keep a handle on. So that's oftentimes missed in a sense. It's like one and done. Well, you had this and you had that, it was treated, and so that's the end of it. So it's constant vigilance. That really stems from a good doctor-patient relationship. Unfortunately, patients, they may not get the best treatment from one neurologist. They go to another, and when you get to the fourth neurologist, and they find out that you've seen 3 other neurologists already, you tend to get short shrift of it again. It's difficult. We have to try to develop an ability to have people concerned about chronic neurological, quasi-neurosurgical problems that stick with it and deal with the chronic care issues. I mean, everybody's concerned about the acute management of things, not sort of the chronic evolution. It involves a good doctor-patient relationship, which is something that needs to be established.
Yeah, absolutely. The only way you're going to get through those really chronic conditions and chronic problems is with a constant back and forth with a physician that you trust.
Right.
Yeah.
And unfortunately, that's hard to come by nowadays. I'm sorry to say, it's
really unfortunate. I think in your experience, what's a typical time frame for seeing headache relief after decompression? Is there a certain time frame where you say headache relief isn't going to go away, and at that point, what do you do?
I think many patients will wake up saying, I just had brain surgery and my headache's gone. But we tend to see patients who have good headache relief, and then 3 to 6 months later say the headache comes back. So we need to say, what is that? And oftentimes that is got to do with raised intracranial pressure, or, for lack of a better term, pseudotumor-like processes, which need to be looked at. We began to do spinal taps, looking at intracranial pressure. The average, and that's been looked at. Dr. Keating, I think, talked about it. We've looked at a lot of patients, maybe 30% of patients after surgery have pressures that range above 230, 240 millimeters of water, which is clearly elevated. It's not going to give you a shunt, but it's still raised intracranial pressure. That may be aggravated by activities and the like. And so we tended to be pretty aggressive about using Diamox, monitoring, bolting patients for pressure, and seeing, how we managed intracranial pressure that way. I mean, a shunt is the last thing you want to do for a patient because it's a labor of love and it's never ending. Pediatricians really that deal with kids with shunts know that it's a nightmare. The average kid with a shunt in his head after a year has 17 to 20 shunt revisions before they're 30 years old. And it's really agonizing. So we want to have a high threshold for putting a shunt in, but we want to treat those patients to manage intracranial pressure in some way. And hopefully good management of that mechanisms by way of looking at it. I mean, there are some new techniques looking at intracranial pressure by ophthalmologic techniques. We were, like to do LP studies and infusions, where we would, infuse, take spinal fluid off and then put it back in. And these patients oftentimes had difficulty absorbing spinal fluid, and that's usually where the problem is. After surgery, everybody makes about 1/3 of a cc of spinal fluid a minute. That's, in the course of a day, you make 3 times the amount of spinal fluid you have. The average spinal fluid space is about 150 cc's of fluid, and you make 3 times that much. So that fluid has got to be absorbed, and it's passively absorbed. It's passively absorbed through the granulations at the top of the head into the sagittal sinus and along some of the similar conduits in the spinal cord. About 10% is absorbed in the spinal canal. Most of it is absorbed within the head. But it's a passive, and that gets clogged up by chronic inflammation, blood in the spinal fluid after surgery. So if you've had 2 or 3 Chiari decompressions, you've had inflammation, you've had blood in the spinal fluid, all of that can clog up these absorptive pathways. So for the most part, patients have poor absorption of spinal fluid, and that's a kind of pseudotumor in a sense. It raises intracranial pressure. When you look at the dynamics of pressure, when you decrease absorption, the spinal fluid pressure begins to gradually rise. And so it would be nice to have better strategies to medically limit spinal fluid production. Right now, there's not a lot, that we can do, and you need a close relationship with a neurosurgeon who's willing to monitor intracranial pressure with bolting and the like. They don't tend to do that. Neurosurgeons bolt patients when they have terrible cranial trauma in the emergency room. It's a little bit of a risky procedure. You got to, you have to make a hole in the skull and put a probe in the cortex. All right. So just to measure the spinal fluid, the other alternative is to put a needle in the spine, and a lot of people don't like to do that when there's a Chiari present. So you have to have good strategies to look at that, and hopefully we'll be able to develop ways by, there are some techniques people have been trying to do by looking at the pulsatility in the jugular vessels, by looking at ocular pulsatility to maybe measure, to looking in the ear, look at pulse waves in the ear to measure intracranial pressure in the posterior fossa. Those techniques, some of them have been looked at in Germany and in Europe, and it's not been an area that people are very interested in the United States. And that's where we need to direct some attention so we can better monitor intracranial pressure.
Yeah, I'd be happy to work on that with you. Before I kind of ask a question about some Syringomyelia specific stuff, there was a question that came in the chat about, can Diamox be used long term, and do the side effects lessen or worsen over time at all?
Well, the side effects are, sometimes tolerable, sometimes not. I've used Diamox effectively for 10 or 15 years, but the natural history of this is that it generally, the absorptive capacity may decrease a little bit, and patients either get through and get old enough, their brain shrinks a little bit, and they're copacetic, or they need surgery. So it's not something that works for everybody long term. And I would say, for the most part, patients may get some relief, but they ultimately come to surgery. It's just the nature of the natural history of this pressure-like problem and the frictional elements at the craniocervical junction that lead to restriction of movement of spinal fluid, you know.
Yeah.
So that's where the problem is. What do we do long term for this? Because oftentimes the medical approaches begin to fail at a certain point, you know.
Right. So I kind of want to talk about Syringomyelia for a second. There was a question that came in the chat, and I think the person who asked it just left, so I feel really bad. But their Syringomyelia was caused by actually a fungal infection, and I am not going to even bother trying to pronounce it. Coccidioidomycosis.
Coccidioidomycosis. Yes.
You got it.
Yeah. It's a very, very, very rare and unusual problem. Generally seen more in the Southwest because you know, these fungal agents grow in the ground there, and dust. You know, you catch it from inhaling dust from the ground.
Right.
Not so common in the East Coast.
How does that happen? And then are there any alternative recommendations to treating that other than surgery, or is that the only option?
Well, I mean, you know, the problem is once you have inflammation and it heals, the process doesn't actually go away. It just has, you know, reaches a stage. So some of these things can be a little bit progressive. It's just like, you know, we used to think that chronic traumatic encephalopathy was chronic and didn't go anyplace. Now we know from looking at all the NFL football folks that trauma produces chronic changes that are progressive in nature for the most part. And that's an important observation. Changes that take place, many of these NFL football players that have gifted their brains to neurosurgical institutes have found that there are progressive changes akin to Alzheimer's disease and other forms of dementia that are unexpected except for the history of trauma. You know, it's not so good to bang your head around. And I think for the first time in a couple of years, we've begun to see on Long Island, for instance, which is a hotbed for football teams, that the enlistment of freshmen and sophomore in football has markedly decreased over the last couple of years, because parents are just saying, you know, I don't want you playing, I don't want you getting your head banged around, you know, and you know, in girls, it stands in soccer. Lateral impacts that oftentimes are more common in soccer and in field hockey in girls are particularly around menstrual cycle areas can be not so healthy for you, you know. Even if it's subconcussive, you know, it's kind of just got my bell rung, you know, but it's better not to have, you know. So unfortunately, I love football, but I think in another few years, we're not going to see contact sports the way it's dwindling, you know, and there's some good reasons for it, you know.
Yeah, and I mean, a global pandemic probably isn't helping.
Yeah.
But I actually want to go back a little bit to some behavioral stuff. So there were two questions that had actually come in after surgery. So this is, again, something that a neurologist would start to take up. These children or adolescents are experiencing anger, emotional regression, social regression, psychological issues. Is there any correlation between Chiari, Syrinx, and emotional psychological well-being of a patient, especially a child? And is it common to develop behavioral issues after surgery?
Well, I don't think there's anything that's associated with Chiari other than the aftermath of Chiari-related problems. So Chiari in itself is not associated with that kind of behavioral problem as a given. We do tend to see with craniosynostosis and other things that cause increased intracranial pressure and tonsillar descent that there are chronic neurodevelopmental problems in some of those, but the standard kind of Chiari we're talking about, or EDS and mixtures of all of these related disorders, there really isn't any of that, and a lot of it is associated with just chronic painful conditions that may not be maybe as addressed as well as they should be, you know. So adolescent development and chronic illness in adolescence is a very, very difficult and serious problem. It's not necessarily associated with Chiari. It's associated with chronic illness, and headache being one of them, And certainly in the EDS population, we see an awful lot of issues with chronic, psychosocial issues related to chronic illness like that.
Yeah. I'm sorry we're bouncing around so much. There are like so many different questions. I just want to make sure I get to them all.
Well, keep them coming. I can stay here till midnight. My Wi-Fi would be done before midnight, so.
Stay agile. So after surgery, a patient had noticed that they had increased floaters, so visual issues. Some of his or her physicians noticed that they saw the floaters and others didn't. The patient reports that they seem to increase when they're not doing certain neck exercises, or when they're not using a General. I don't know if I'm pronouncing that properly, but it's when you put a piece in between your neck, so it kind of like stretches it and elongates it. Is that Chiari or something else?
Well, I don't know that we know too much about that, but the issue of floaters has been something that has been described in Chiari. Now, whether that has to do with pressure, intraocular pressure that may be somewhat increased because of the extension of intracranial pressure and compression along the optic nerve tract, all right? Because the CSF space extends out along the optic nerves to the optic orbit, the optic globe itself. And so we call that papilledema and a choked disc. But, it's been well recognized that patients with raised intracranial pressure tend to have an increased amount of floaters. Patients with farsightedness tend to have it for some reason too. Generally, these folks congenitally have larger eyeballs, all right? And that's farsightedness. A myopic individual or a nearsighted person tends to have a smaller optic, globe. We use glasses to bring the image back to the right position. So we use magnifying lenses for hyperopes and minimizing glasses for patients that are myopes. So you can oftentimes tell what a patient is by looking at the side of their eyes through their glasses. So your glasses are a little bit magnifying, all right? But they're not much so. Sometimes you can see that if you look at the eyes and look at the side of the face, that face looks bigger behind the glasses, Whereas patients that are myopes, if you look, their eyes look smaller because the lenses are making the eyes look smaller when you look through the glasses as an observer of the eyes, So I lost train of where we were going with this.
Floaters.
Floaters. So hyperopes tend to have more floaters. I'm not sure exactly why. And there isn't any particular ocular thing associated with Chiari that I'm aware of. They're not particularly farsighted or nearsighted, so I don't see an association that way, Floaters are fairly common, everybody has them to a certain extent, and they're very variable. I have a lot of them myself, and sometimes I see tons of them and they're very annoying, and other times I don't notice it, So it can drive you crazy though. Some people get nutso with it,
Right. So again, post-surgery, and then this is the same patient that was doing the martial arts and then stopped abruptly because of COVID. Is there anything that this patient would be able to do? So they describe that they feel their body shaking internally in their torso, and their fingers get extremely cold. And I know what that sounds like to me, but I wonder what you would call that, and then how you would manage that symptom.
Well, it sounds like those might be residual Syrinx related symptoms. A patient had a Syrinx. I think as long as they can tolerate activity, there's no reason to stop activity. For COVID, doing sports in a gym and whatnot is obviously got everybody restricted. But I just tell patients, don't do anything that hurts. if you're lifting, lifting weights and when you try to curl 150 pounds, if it gives you a headache, stop doing that, but do reps of lighter weights so you stay in good condition. And and core strengthening and it is very important in functioning in general. And when you have headache and you don't become and you do less activity, that's where you begin to have problems. You get fatigue, and you lose you lose your core strengthening, which is something that physical therapy. I'm in physical therapy twice a week with this other problem that I've had with Cauda-Equina syndrome and whatnot, and I can see that I just got back into physical therapy, and it's made an incredible difference in my balance and other things, which I thought would be a good thing, but it's really been a very positive thing. So it's very important. I have a much more healthy respect for physical therapists than I did as a simple neurologist.
Well, that's good. So would you argue that maybe the martial arts, when possible, it would be something good to possibly pick back up if it was helping those symptoms originally?
What bothers me about martial arts is there's a lot of kicking and headbutting and whatever else. I would definitely discourage that kind of thing, but a lot of martial arts is doing karate forms where people are doing certain movements. It's almost like Tai Chi, and I think I recommend people do Tai Chi a lot, because it's very good conditioning and core strengthening without a lot of exertional effect. So Tai Chi is probably if you want to recommend people get into something that is group oriented, that you can do at your YMCA or wherever, Tai Chi is a good thing to do.
Yeah, that kind of goes into this next question I wanted to talk about. So a patient was having issues with some problems, they think, with their vagus nerve. So everyday life is being impacted. So bowels, bladder, gut, headache, loss of feeling in the hands and feet, pain everywhere. The added caveat is that this patient also happens to be on chemo, and they've noticed that it's gotten worse after infusions. So the question really is,
I remember that question, but infusions of what? Infusions of chemo?
I assume chemotherapy.
I assume, yeah. So that's I've had my experience with that too, and that's it's that's a nasty issue, and those things can be difficult to tolerate, So I think
so this patient had Syringomyelia and had surgery. I think what they mean by this is that their symptoms get worse with Valsalva, which is kind of what we were talking about with the different Tai Chi, non-Tai Chi. So would vagus nerve stimulation be something that would help with that, or?
Well, I don't know. The main thing you want to know is whether the Syrinx has recurred, because if they do Valsalva, Valsalva maneuvers can aggravate Syringomyelia symptoms, because when you do a Valsalva, you're basically compressing the spinal cord, and many patients will have symptoms that can be a symptom of Syringomyelia. So you want to have a look at that and see that the Syrinx is not recurred, or it's not enlarged, or it's not changed at all. That would be my most important thing to look at.
Would there be any reason that I mean, this is a very small number of people, but would chemotherapy infusions, would that worsen Syringomyelia symptoms in any way?
I don't think it would have anything to do with that, but it depending on what kind of chemo you're getting, it can give you some chemos like vincristine can cause a lot of numbness and tingling. Others can cause tremendous diarrhea and gastrointestinal problems. And severe fatigue. So it depends on what the chemo is, and that's something they have to discuss with the oncology guys as well.
Yeah, absolutely. Staying with Syrinx for a second, is there anything that can be done for spinal cord atrophy with the Syrinx, and is there any way to detect that early before it happens?
Well, once it's generally a good thing for the syrinx to collapse, but as we discussed a little bit before, sometimes the symptoms get worse when the syrinx collapses, and some of these pathways that have been distracted, become a little healthier, and they're healthier in a bad way. So I think when syrinxes collapse, maybe 10 or 15% of patients notice worsening of and it's very it's very discouraging because they're happy to see the syrinx collapse, but if your pain gets worse, that's not an easy bargain. You just have to approach treating the pain problem with whatever you can. Neuropathic treatments for pain, not necessarily opioids and stuff, getting away from that, but using things like Topamax, gabapentin, biofeedback, and whatever you can throw at them to try to control the pain experience.
Mm-hmm. There's another question here. Someone's son had Chiari and had symptoms of a CSF leak for several years, but it was untreated. So I assume that means that they could get through the day without it being really, really debilitating.
The leak apparently was, where was the leak? The leak was apparently at the posterior fossa, I'm assuming.
So they said that recently they developed a bone marrow edema in the sacrum, like in the sacral area.
That's what I wonder where the leak was coming from, whether it was
but they were asking, is that caused by the leak, the syringomyelia, or maybe even the tethered spine? Is there any way to tell?
Well, I think you need to figure out what's going on, because from that question, when I looked at that question, I said, well, we don't have enough information. I mean, is the cord tethered? Is there a thoracic syrinx? Where do we stand now? We need to look at that. That needs to be, start from scratch again and re-image the entire neuroaxis.
Yeah. It's because it's really hard to figure out what caused what there.
And these CSF leaks are very difficult to deal with. We've had some success doing with it. Dr. Blocking on his name in California is
Batzdorf?
What?
Batzdorf?
No, not Batzdorf, but he's in Los. I can't think of his name. He's a neurosurgeon, very great guy. Talked at a couple of our meetings.
Gerald Grant?
No, he's in Los Angeles at Cedars-Sinai.
Sheeving, Dr. Sheeving.
Sheeving. Yes, I mean he's made a hobby of this in a very good way, and has got a lot of techniques to look at. So doing things like MR myelography. All right, so we think about myelograms with contrast, but you can do MR myelography to look for CSF leakage. All right, it's a high T2 intensity image where you can see what the spinal fluid is actually doing and whether spinal fluid is leaking through the dura to look for CSF leaks. It's a labor intensive kind of way to approach it, but we became more interested in it because the EDS patient population has this interesting problem. When you lay them down, their pressure in their head goes up. When you stand them up, it goes too low, because it's just like orthostatic hypotension. They have orthostatic CSF pressure changes. So when they lay down, all of fluid rushes to their head, and they have high pressure symptoms. When they stand up, everything runs to the dilated dura in the lumbosacral area, and they have low pressure symptoms. So what are you dealing with? High pressure, low pressure? If you take spinal fluid off, you make certain things worse. Dr. Bolognese attempted to manage a couple of these patients by putting sleeves around the dura to keep the dura from expanding. And that was successful in some patients, but it's really a difficult problem, because they have orthostatic CSF changes, so their pressure is never what they want it to be,
Yeah. A question came in the chat. This is loaded. How do you make sure neurosurgeons understand the severity of syringomyelia over the long term? So many like to wait and see and monitor and see how people do. And would you say that there's anything that would be concerning if it wasn't addressed quickly? As far as, because we've been talking about some residual symptoms from Syrinx over time.
Yes. Well, I think the question is, to try to get in touch with a person that's interested in this in a way, so that, they're not just patting you on the head and saying, come back in a year and let's see if anything changes. But they have a strategic plan to monitor you at 3 months, at 6 months, and see. Years ago when MRIs first came along and patients were MRI'd and they found a Syrinx, some neurosurgeons would go and put shunts in them. Some of these patients may have had chronic Syrinx cavities that were just hanging out there, and sometimes the surgical treatments made them incredibly worse. So we're concerned about syringomyelia if it's changing. In other words, if it's expanding. If you just have a syringomyelia cavity, it may have been there for 10 years. What's important is what is the correlation with the clinical symptoms, and is the Syrinx changing? If the Syrinx is expanding, then something needs to be done about it, probably in the right hands, and somebody that's got experience managing syringomyelia like that.
Yeah. Is there any size Syrinx that maybe, this is my own question because I'm not sure, might be concerning that would
Well,
require?
I'll tell you, I have this one lovely patient of mine who you can barely see her spinal cord, all right? She has a humongous Syrinx. She's almost totally asymptomatic. And with trepidation, I showed the imaging to Dr. Miller, and I said, well, what are we going to do about this? And he said, what's she complaining about? I said, nothing. She said, I wouldn't touch her at all. But she's likely to do worse with time. So when do you pull the trigger on something like that? Dr. Bolognese, I think, is a little more aggressive about it, because waiting too long can have problems as well, but you just have to kind of, I think, be willing to follow the patient longitudinally rather than going from neurosurgeon to neurosurgeon. Try to find somebody with a commitment to it, and try to stick with somebody that will look at it longitudinally to kind of, and hopefully somebody that does this, that isn't, they're really just not the intent. So most neurosurgeons haven't had that much experience with syringomyelia, and many would not, begin to mess with the posterior fossa or to mess with Syrinx shunting, but not that they might not try it, but you want somebody that really has an experience with the management chronically of these kinds of conditions. There are people out there like Dr. Bolognese, Petra Klinga, Shivink, and others that have expertise. Dr. Oro, Dr. Keating, Dr. Batzdorf for sure, who's the masterful person that's been so pivotal in all our evaluation and understanding of these conditions. So there's a lot to be learned. It's I'm just amazed that when you start studying something, you think it's that it's a rare circumstance. And the more you learn about it, the more you realize you need to learn about it, and the more you do learn about it, and you think there's no end to how much you can learn about some of these things. And it seems to be the more you know, the more complicated it seems, and it's not exactly right. You should come to a point where you totally understand it, but that's not the case in these conditions. We just need to know an awful lot more, and we're gradually getting there. But it's difficult because these are rare conditions, so there's not a lot of national impetus to understand and work on these things. So it takes a dedicated few people with a commitment to it, and a good. That's where patient organizations like CSF are so instrumental in bringing these things to notice and organizing patients so that their voice can be heard. And
Absolutely.
so that's why, as physicians, we're so happy to contribute and be involved in organizations like CSF and ASAP and if I can say that.
You can. I'm actually going to ask you a question about that later, but it's really important. And I mean, there's a whole psychological literature about the more you know, the more you realize you don't know. So I think that's exactly what's happening.
Yes, that's.
Okay, so I have one more question before. There are two more questions that came in earlier. So if anyone has any questions to come in at the last minute, now's the time. But one of the questions was, there was a patient who had some pressure issues Botox had helped different symptoms over time, but she had noticed that her syncope had gotten worse over the last few months. She had been up to a mile a day of a walk that was comfortable, but recently, a quarter of the way into that mile, she realized she couldn't breathe. And she was having some really concerning pulse ox issues where it was dropping all the way to 90, 95. They'd been testing her heart for like different heart Holter monitor kind of stuff. She'd been having fainting episodes. She actually has a stress test coming up soon, so she doesn't have any results from that. But is there any recommendations other than like my break glass in case of emergency, brain's going off about like COVID, but is there something else that might be causing some difficulty breathing and different stuff like that that she can maybe get treated by a cardiologist or a neurologist? What could that possibly be?
Well, it's so the symptoms need to be refined a little bit. I mean, is there if her oxygen levels are low, then that suggests a primary some degree of pulmonary problem. Although pulse oxes of 95 are not that bad. Most people, certainly if you get into the 80s, you begin to feel like you really have some air hunger. But we just need more information. And in the good hands, she should be in a good pulmonology, and then take stock of everything in a comprehensive way.
Yeah. Okay, we got a couple of questions that came in, so I'm going to go this first.
Sure.
This actually is one of the questions that I was going to ask. Is it common for a surgeon to cut through the axis, so like that C1 area during a Chiari decompression? And if they do, does the C-spine have to be fused in order to prevent pitching, so like the neck from moving too far forward to cause extreme pain? Is that common?
Well, the question is, how is a decompression done? So years ago, there was just decreasing the opening the back of the skull and taking off the back of C1. All right. What that produced sometimes was some instability, not just EDS related, but a tendency for the odontoid to press forward. So people started doing then odontoidectomies. But when you couple an odontoidectomy with the posterior, you have to stabilize the skull on C1 and C2. So if you do an odontoidectomy, you have to do some kind of stabilization of that craniocervical junction. Some people have had success with rotational instability by just doing cable graft fusions, just tying C1 and C2 together, and that sometimes can be helpful. But if there is odontoid movement, and Dr. Miller, initially when they were doing decompressions, they used to automatically couple an odontoidectomy with that. But they found if they extracted the head a little bit, they popped the odontoid out. If you fused them posteriorly, you didn't have to go through the throat, which is not a nasty operation, So they developed this technique where there were condylar screws, so the condylar screws can fix the skull on C1. Right? You don't need to mess with the odontoid, and the odontoid is taken out of the picture by extracting the head on the cervical spine and fusing that relationship by condylar screws. Condylar screw technique is not widely done in craniocervical fusions. Most neurosurgeons that are doing it are doing posterior fusions. All right, Dr. Bolognese and one or two other people in the country will do that. These are long screws that go through C1 into the condyles, and they're over and under the 12th cranial nerve, the vertebral artery, and it's a dicey operation. And Bolognese, for instance, has done over 300 of these. So you need a certain amount of skill in terms of how do you go about doing it with intraoperative imaging and the like to not get into complications. But so a lot of neurosurgeons, unless they're maybe trauma surgeons or whatever, they're a little afraid to do this, it's
definitely risky.
Definitely, it really increases the risk of the surgery,
Yeah, absolutely. In the presence of this is a question that came in the presence of a retroflexed odontoid causing ventral brainstem compression, so similar to what we were kind of getting at, is there a concern for long-term damage to the brainstem from that pressure, or no?
Well, I think we're dealing with the same thing when you open up the post, posterior fossa and look at the tonsils from friction and others. You see matted tonsils, you see adhesions with the dura. Certainly anterior compression has got to have some similar impact on the ventral brainstem. Now, you don't really get a chance to see that unless you're having an autopsy done. And luckily, most Chiari patients don't need an autopsy and end up coming to that strategy. So that's the good news. But there clearly can be some problems with, chronic pummeling of the anterior brainstem with the odontoid. Now, those myelinated structures are probably a little more resilient than the posterior areas, which are more gray. There's more gray matter posteriorly than myelinated structures anteriorly. So, I think, and laterally. So, what you get into in the Chiari situation, not only posterior impact, frontal impact, but lateral impact. That can be seen when they really look at axial images to see how much lateral impaction there is. Because sometimes you'll see a posterior fossa is done beautifully, but the tonsils wrap around and the brainstem is crushed in between. It's like a little heart-shaped structure. So so what about getting at those tonsils? That's a dicey business, all right? You've got to right behind that tonsil is the vertebral artery and the 12th cranial nerve fibers. It's so it's a delicate area. If you disturb the vertebral artery and you get clot formation, you can infarct the brainstem, which is a serious business. So it's, Dr. Bolognese, these operations are 9, 10, 12, 13 hours, all right? Inch by inch, slowly we went. So, it's really tough surgery,
Yeah. You want to go to someone who has done at least their share.
Yes, that's the issue.
Yeah. Okay, so 3 more questions. First, for mild craniocervical instability, would you consider trying Botox in the neck, or is that going to cause more muscle weakness over time? What do you think?
I don't see much of the point of Botox, it's kind of maybe aggravate things a little bit, There's also, there's a vogue with some of the folks for doing collagen injections, Proline and Prolia, what are they? They inject collagen, things like you plump your lips up and things like that, and various other structures that need plumping. But I think that's kind of a dicey business, and I don't see it doing much. It's if anything, it's transient, and it's risky business, I think.
Yeah.
And I haven't seen too many people. Mostly, it's a little bit more done on the West Coast for some reason. I don't know. So
I think they're just so used to using Botox over there.
Yes.
Okay, so this is a really good question. This person's been diagnosed with both Syringomyelia and Fibromyalgia. They were once told that Fibromyalgia was diagnosed basically because some neurologists don't know what Syringomyelia is or really understand it. Do they correlate at all, or are they completely different situations? And I know that's like a 3-hour-long answer. But
yes, well, I remember we did one of these talks about 4 or 5 years ago, and the question is, does Chiari cause fibromyalgia? Well, fibromyalgia is kind of a wastebasket. It's not really a diagnosis. It's just a symptom description. So painful muscles and it's. I don't even like to use that term. You want to get more specific about really what's going on. It's a wastebasket term that's throwing your hands up and really not addressing the issues. And there's no specific treatment for it. I think being involved in physical therapy approaches and other things that we've talked about already are the way to go with that.
Yeah. It's almost like if you get a diagnosis of fibromyalgia, you should probably go back to either your same doctor or a different one and see what might be the issue.
Yeah, because you know, they say fibromyalgia is 35% of rheumatology practices is fibromyalgia. You know, and so again, it's a wastebasket, and it gives a diagnosis, but it's not a diagnosis. It's just a description. Well, you know, it hurts. You know, so.
It's a little lazy, I would say.
Well, it's something you can bill for. You know, I treated fibromyalgia. You know, so.
Oh God, don't get me started. So there was a question that Chiarians were at greater risk for contracting COVID-19, and I don't know if you can just speak to that a little bit.
Well,
are they at greater risk?
That question did come up. They're not at greater risk of getting it. We're all at risk of getting it because it's amazingly contagious illness. That's the big problem. That's why it's so bad. It's amazingly contagious. For the most part, it's not bad, but it can kill you. So you've got this dichotomy of, you know, well, my goodness, what do you do? Chiari patients aren't more at risk of that. They're not, there's no predisposition to it. But, you know, when you get at the question of chronic inflammation and stuff, you know, it's been said that if you have COVID, you have increasing IL-6, you know, these interleukin storms and whatnot. Those things sort of have an association with some degree of chronic inflammatory, like chemical meningitis or an inflammatory, you know, like what, you know, if you get the flu, you get a headache. If we tapped everybody that had the flu, we would see cells in the spinal fluid in a number of those patients. We call it aseptic meningitis. All right. Viral diseases have a penchant for doing that. We don't like to necessarily tap all those people because what do you do if you get cells? Do you treat them with 3 antibiotics, including, you know, TB and everything? So it's almost like people don't want to go there because for the most part, 99% of the time, it's not an issue. But COVID, I mean, people have looked at spinal fluid and so on, and there is some inflammatory component to that. So to the extent that COVID problems cause central nervous system low-grade inflammation, it could aggravate, you know, Chiari processes. You know, so patients shouldn't be looking to rub themselves together with other patients just to get exposed to Chiari, to get exposed to COVID and hopefully survive it without much trouble. I wouldn't put yourself at risk, you know.
Absolutely. Yeah, no, I agree. We've been talking about this on the past couple of Q&As. That's kind of why I wanted to broach it with you, because you're more in the cellular bio realm of with neuro and all that stuff. So like all the surgeons just cut and dice, but you kind of understand more of the cell bio of all of that, and there's some element of increased risk if you have the virus, but if you do all the things that everyone's been telling you to do, washing your hands, social distancing, all that stuff, you're good.
All of that, that's the key to success. And that's why when areas have done well, that's what it's due to, you know, just because this is a extremely contagious. That's why it's a novel, you know, it was billed as a Tony Fauci was my chief resident in medicine.
Oh my
God.
So
I haven't talked to him for about 35 years. I'm afraid to call him because he's
you gotta call him.
he's so inundated, but he was an excellent role model for me 45 years ago, and I'm happy to see that he's still at it. He's getting beat up a lot, but he's an excellent physician and a swell guy on top of it. And you know, it's an interesting course of events, you know.
Weird times for sure.
Yes. But he was my chief resident in medicine at Cornell for
That's so funny.
Back in 72, 74.
Don't age yourself. You're fine.
Hard to count back that far, you know.
No,
I remember I sent my information onto someplace, and you know, I put in where I had been trained in various places, and they called me back and they said, well, you were we tried to get some information on you from the public health service, and they said you were never in the public health service. I said, that's not possible because I was in the public health service. So I called the public health service, and they said, well, we don't go back that far. And I said, well, I ain't not dead yet. So please release the information because they think I'm lying to them that I was there in 1986.
Oh, no.
So we finally got it straightened out, you know, but there are some perils to living too long, I suppose. You know.
It's a little offensive at the time, for sure. But all right, well, I want to thank Dr. Kula so much for being with us and for talking about all this stuff with us. I know we were all over the place. The questions we got were like in every different realm. I couldn't even compact them into one.
Well, Caitlin, I want to compliment you on how well you've been able to structure the questions, and our interchange has been amazingly good, and I think it's helped me, and I'm sure it's helped the patients. So you've done an excellent job. Okay. And you always do, actually. I miss seeing you in person, and maybe
miss you.
Say goodbye to Dorothy for me. I miss her.
Oh, well, they're here.
And also Mary. Is she?